and welcome to another podcast. Today we're going to have a look at spinal trauma. Spinal trauma is one of those things that tends to get people a little bit paranoid around patient care, and everyone, especially in the past, was very overcautious, if you will, with spinal cord precautions. And there's been a lot of evolution in studies and practices over the last 10 to 15 years. So today we're going to focus on the division of spinal trauma, being those that have evidence of a spinal cord injury and those that have the potential of gaining a spinal cord injury, and how our management should alter associated with two different types of casualties. In reality, a person with spinal cord injury requires high-end care and, in most cases, long-term rehabilitation. But the actions that we play on the ground in the pre-hospital space can really dictate the outcomes and the duration of that person's recovery in the long term. So as always, we'll start with an introduction of spinal cord injuries as an overview and just start getting a few classifications and understandings of what sort of statistics are out there associated with the injury itself. So spinal cord injury is a classification of a debilitating, which is a real understatement in some cases, neurological condition. So any spinal cord injury of varying degrees will cause some sort of neurological impairment that can be long-term or can be irreversible. Now the numbers are difficult to find and there's a lot of different things out there, but the best study that was current says that there's around 12,500 new cases of spinal cord injuries just in North America alone. Okay, so it's actually quite a prevalent injury when you consider that that is actually confirmed cases of spinal cord injuries, not people we suspect, but actually quantified spinal cord injuries. And when you think about 90% of those coming from traumatic events, it makes it even more surprising that even with all the safety measures that have been put into place, like seat belts, warnings, and life jackets, and all these things, we're still having high cases of spinal cord injuries, relatively, and 90% of them are still caused by trauma. Now, when we look at the division between the sexes, it's actually quite interesting. So when we get the total number of people with spinal cord injuries, males outweigh the females, a ratio of 2 to 1. So that's when all the spectrum of numbers are put together, which shouldn't be very surprising for anyone who's been in the medical field, because we tend to know that males tend to put themselves in situations where trauma is more likely, and they tend to take more risks at certain age groups. But what was very surprising in the numbers, at least to me, was the fact that females aged 15 to 19 are more prevalent in that age group than men. So anyone between 15 and 19, females have a more likely probability of having a spinal cord injuries. But if you extend that age out from 16 to 30, then 80% of all those cases are men. So after the age of 19, there is a massive spike in cases of men with spinal cord injuries. Now, you could surmise that that's mostly due to motor vehicle accidents and young males driving, and you'll be right. That coupled with boating accidents, diving in waters, risky behavior, drinking, those sort of things also play a big role. Now, as far as outcomes go and morbidity and mortality, anyone with a spinal cord injury over the age of 60 tend to have worse outcomes than those that are under. And this links closely to criteria that have been made, like Nexus and high risk criteria that we'll talk about later on. As far as regionally goes, the most probable place to get a spinal cord injury is within that cervical region. Okay? Not surprising, you've got a large, heavy head sitting on top of a bunch of small bones, so it's not surprising that that's where most of the injuries occur. The thoracic cavity constitutes 35%, and the lumbar region sits around 11%. And the rest, you've got your sacral, or a mix of those three areas. Now, people that have studied spinal cord injuries in the past may have an understanding of neurogenic shock, which is fundamentally different to spinal shock. However, the terms tend to get interchange freely. Neurogenic shock is a form of distributive shock that results from an unopposed parasympathetic response. Okay, and we'll look a little bit deeper into what neurogenic shock is, but it is the worst outcome of spinal cord injuries. And the presence of neurogenic shock in varying degrees accounts for 19% of cases. So you're looking at around a ratio of 1 in 5 spinal cord injuries actually resulting in neurogenic shock. And this is actually extremely irrelevant when it's got to do with management, because the management of a patient with neurogenic shock is inherently difficult to do in the pre-hospital space. And some would argue that proper management is impossible to do in the pre-hospital space with true neurogenic shock. Okay, so just consider those numbers and we'll look through the management of neurogenic shock and then those with other types of spinal cord injuries. But before we get there, we'll have a little bit of look at the anatomy. Now, I won't spend too much time talking about the vertebral column. Obviously, that's the bony spine made up of all the different regions: cervical, thoracic, lumbar, sacral, coccyx, if you want to get really technical. And obviously, you have vertebrae, and in between the vertebrae, you have intervertebral discs, and then from there, you have nerve endings that will actually branch out. And it's the branching out of these nerve endings and the way that they actually work that makes it unique, and particular when we're dealing with spinal cord injuries. But just as a refresher, when we talk about the division of the actual vertebral column, we're not going to go into the numbers of cervical or thoracic or anything like that, because what's relevant today as far as symptoms go is the division of the autonomic nervous system, okay, the parasympathetic and sympathetic nervous system. So the parasympathetic nervous system, for memory, okay, for you, is cranial and sacral. So the division is cranial nerves and sacral. And the sympathetic nervous system is the rest. So cervical all the way down to lumbar is where the sympathetic roots lie. So when you have a spinal cord injury, most of the symptoms are associated with a loss of sympathetic nervous system functions. But on top of that, and other actions that the spinal cords mediate, is obviously the sensory and the motor neurons as well for the different regions. So if we look at the division of nerves that come out from the spinal nerves, we have the ventral region of the spine and we have the dorsal region of the spine. So the ventral region is the front of the spine, dorsal is the back. Now, sitting mostly in the ventral region is your motor neuron. The motor neuron will go through the grey matter and process information from the sensory neuron or the dorsal root and then put out a response in order to create an action. And that happens at the front, so an anterior aspect of the spine. The posterior aspect of the spine takes care of your sensory input, and there's a clear division. And in the middle of all your spine, you'll actually have grey matter. And if you remember back to the central nervous system, the grey matter is the area of demyelinated neurons that allow for multiple pathways of information to occur. And the white matter that surrounds it is just transient fibers, okay, just fibers that are passing things on. So each side of the spine will have both a dorsal root and a ventral root or a motor neuron. And the division occurs through anterior and posterior area. And each side, left and right, is obviously responsible for the sensory input from that region and the motor control from that region. So when we start looking at spinal cord injuries, we can have a division of where the injury has occurred, which will result in different signs and symptoms based on the damage and the loss of that particular neural capability. One of the biggest clues we have when dealing with spinal cord injury is mechanism of injury. Okay, it cannot be overstated enough that mechanism of injury plays a massive role in our management of spinal cord injury. A lot of the times, if we suspect spinal cord injury, it provokes some sort of application or preventative measures. Now, the classic mechanisms of injuries that result in spinal cord injuries include your hyperflexion and your hyperextension. basically where you get forced to look down or violently forced to look up if someone hits you in the back. Okay, they're the most common causes of your spinal cord injury. On top of that, you can also have twisting motions, which is quite rare and difficult to pick up, but it usually results in some sort of whiplash and the person's unable to move their head around as a result of that particular trauma. You can get side, so actual lateral movements of the spine, which can cause compression on the collateral side, generally resulting in secondary injuries from there. Accidental loading is definitely a consideration. If people jump into water, land on their head, they tend to put all that force through and it loads into a point, finds a point of weakness or where greatest force is actually generated and causes almost like a crush fracture or inflammation of the area, which puts pressure on the spine itself. So we'll go through a few high risk criteria or mechanisms that you need to consider that have the highest probability of injury, and then those criteria pretty much overrule any other nexus criteria of proper management of spinal cord injuries. So as mentioned, when we look at the anatomy physiology, anterior, posterior aspects and collateral sides that the spine takes care of, mix that with different sorts of mechanism of injury, we start to get a picture of pathogenesis. Now, on the ground, it's not overtly important for you to get the diagnosis of the particular condition. And a lot of the time in the acute stage, you won't actually be able to pinpoint what is really going on as far as injury goes that will really let you know what sort of disorder or condition the patient is dealing with. The part that we need to know is, like most things in trauma, we have primary trauma, which is associated from the impact or the force on the actual spinal cord itself. And then we have associated secondary injuries, which result as an overreaction from inflammatory processes, edema moving in because of the damage, a reduction in blood flow causing hypoxia, and therefore obviously causing necrosis, or in some cases apoptosis when we're dealing with the pathological lines. So each one of these damages or injuries will result in damage to the tissue of the spinal cord. Now, as mentioned before, this can be complete, like transverse sections of the spinal cord, which means that motor and sensory function all the way down is lost. Lost, that's it. You cannot get it back. Well, not without a lot of work and generally a lot of money as well. And that's where our paraplegia, tetraplegia comes into play, because they lose that function and they will probably never get it back. Okay, so that is a permanent injury. But most of the time, we end up with an incomplete injury that is divided into different regions. So as I mentioned before, we have the anterior cord syndrome, we have the posterior cord syndrome, and as we can see, as mentioned, the anterior cord syndrome is mostly associated with loss of motor function. Posterior cord syndrome is mostly involved with loss of sensories, particularly vibration and proprioception. Okay, so that lines up with the design of the actual vertebral column. When we have central cord syndrome, this is where the injuries can really vary, okay? Because central cord injury means that the damage has occurred right in the center of the actual spinal cord. Now, this is mostly caused by your hyperextension. So being hit in the back and your head thrown back violently can cause a central spinal cord syndrome, because the spinal cord itself is stretched within the fibers and actually causes damage in the internal fibers of the actual spinal cord. Now, general symptoms is you have weakness, motor, and you have sensory problems as well, because the message that's coming through that grey matter is not as clear anymore. There's another one obviously called your Brown-Séquard syndrome, and then you have your Conus-Medalis syndrome as well. Now, the point of all these is not to get a category that we look for, but to look at the different signs and symptoms that you may be able to find when you're dealing with a spinal cord injury. So the typical, I can't move my legs or feel them, isn't the sign associated with spinal cord injury. If you have any sensory or motor impairment or neurological deficit, then that is evidence of a spinal cord injury. May not be evidence of irreversible spinal injury, but there is something pathologically happening in the body that is causing pressure on the spinal cord or a loss of ability to pass on neural pathways within the spinal cord that's resulting in the injury itself. So if we see any of those symptoms at all, then we start implementing pure spinal precautions because we don't want to exacerbate any of those injuries further. So just because someone has the symptoms doesn't mean that we turn off all management to do with spinal cord injuries because they already have it. We protect that area to prevent further damage. If someone has damage from primary trauma, we won't know, but you're not going to necessarily make that worse. But it's the secondary injuries that we need to protect and prevent from causing further harm. And that's basically the principles of spinal cord management. And to help us out with that, we have criteria that we can use in order to denote which patients are more likely to have a spinal cord injury and which patients are not. So this ties in with what we were talking about, but it also brings in the probability of different things that may not have got to that secondary injury stage, but the pathology is there in order to cause a problem later on. So the nexus criteria is a very, very good criteria. Okay, it's been tried and tested many times. On initial testing, it had 99.6% sensitivity, and the worst it's ever received in any study is 95% sensitivity. Okay, so it is a very good criterion. And what it's designed for is to denote those people that are likely to have a spinal cord injury, therefore need to go through imagery. So have to go to a facility where there's CTs, MRIs in order to look at the presence of spinal cord injury. So these nexus criteria is used for trauma patients to determine what sort of facility they need to go to, and also to label the probability of them actually having a spinal cord injury. So in order to pass the nexus criteria, if that's a way to look at it, you need to be absent of all of the following signs. So midline cervical tenderness is pretty self-explanatory. There's no neck pain on palpation on the posterior midline area of the neck. Okay, so that's basically it. You palpate the back of the neck. There's no tenderness, therefore we're good to go. There's no altered mental state. Okay, that ties in with neurological, ties in with head injuries. Okay, and also obviously the link to the neurogenic shock as well. So if there's any altered mental state, which basically means a GCS less than 15, you can't rule out a spinal cord injury. I know it may seem a little bit too high, but that's the recommendation. From there, we have focal neurological deficit, and that's what we were speaking about before. So any of the symptoms that we mentioned before associated with motor weakness, numbness, loss of sensation, even your good old priapism, if you have any of those symptoms, that's a focal neurological deficit. If the patient is impaired in any way, okay, intoxicated by drugs or alcohol, can't rule it out. And if someone has a painful distracting injury. So that rules out a lot of patients associated with motor vehicle accidents or blast injuries and all these sorts of things that come into it, because if someone has an injury that has greater pain stimulus than your midline tenderness would have, then you can't rule out that they need a scan. Okay, but if they don't have any of those things, then you don't actually need a scan. And in reality, you don't need to be worried about the person having a spinal cord injury unless they have one of the high risk criteria. Now, the nexus criteria can be quite difficult to remember. So people have come up with a mnemonic that may be helpful for you, and they use NSAIDs as it in order to divide it up to help people remember what the nexus criteria is. But if you need to, it's in your protocols. Have a look at it after the initial management. Try to decide if they've got or meet the nexus criteria, and then obviously make your decision for definitive care from there. And also the need to expedite evacuation. Now, there is a caveat with the nexus criteria that says that anyone over the age of 65, it's not very useful. Okay, that's why in the high risk criteria, it starts with pretty much anyone over the age of 65 as well. Okay, so studies does not support its usability or reliability for people over the age of 65. So coupled with the nexus criteria, if they don't have any of those, you're not out of the woods yet, because if they have any of the high risk criteria, then it's still recommended that they go through spinal cord precautions and they go for a scan as well. Okay, so in the absence of any neck pain and the ability to rotate the neck 45 degrees left and right is a good sign. If the patient can't do that, then it recommends that they have a scan. Now that sort of links into a other criteria that was made known as the Canadian C-spine rule, okay, which is more denoted on movement. So the recommendation linked with nexus is if it goes through that neck pain, bruising, steps in there, and the inability to move their head from left to right 45 degrees either side, then they will still need a scan. If they have none of the high risk criteria, you also can be very reassured that the probability of a spinal cord injury is extremely unlikely. So if the patient is not over the age of 65, wasn't involved in falls or landing headfirst, diving, jumping from heights, any motor vehicle accident that results in head-on collision, rollovers, ejection from vehicles, all that sort of stuff, anyone who's been involved in a high-speed crash, which is 88, for some reason. Okay, so if you know they're going over 88 kilometers an hour, a high-speed crash, or if someone else has died in the same vehicle, denotes that there was enough force in that vehicle to denote a potential spinal cord injury. And then obviously any other injuries around the clavicle abdominal region associated with the spine. There's enough force to cause damage to that region. There's enough force that can be transferred to the spine. Okay, so this seems like a long and exhausting list, but the reason that they've come into play is because in the past we used to overdo spinal cord management. We used to hard collar everybody, everyone was put on a hard board, everyone was locked in place, and it actually resulted in significantly more harm than good. People were overtly overscanned all the time, and as a result of that, the management of people was pretty poorly done. So we've had new criteria come out in our management that gives us a more reasonable approach based on good studies, good probability mixes, and a criteria that we can hang our hat on that says that in the absence of all these things, this person is very unlikely to have a spine injury. Okay, so that's basically what it means. It doesn't mean it's impossible, but it's very unlikely to have a spine injury in the absence of the nexus criteria and in the absence of the high risk criteria. And we can use that information to really assure us in our management. So when we go into management, we're going to start talking about the management of people who do not meet these criteria or have one of the high risk criteria. So starting right at the big question for everybody is right at the start of general management is what do we do now in the absence of the hard collars? Okay, so hard collars are out. Some of us are very happy about that. Okay, but it does lead the question of, well, what do I do now? What do I do to protect the person's neck now? And the answer is you focus on principles of minimum handling. So you handle the patient as minimal as possible and you maintain immobilization. Things like extrication makes it very difficult for this sort of thing, and I acknowledge that, but the focus needs to be on minimum handling. Once you get them in a position, you leave them in that position. You set yourself up so that you can put them in a position that they're going to stay. You use machines to help you move them. By machines, I even mean simple stretches as well, to move them, to minimize that twisting, rolling, jerking motion. We maintain C-spine inline immobilization. Now, the hard collar used to do that for us, or that was our perception anyways. The hard collar used to do that. Now, even in the best case scenario, when we use those hard collars, the best case scenario, which means put on perfectly on the perfect patient, okay, with a conscious state, the suitability of that hard collar was only 20% for maintaining inline immobilization. Okay, so it was a ruse. It was an absolute farce that we would put these on and think that they were good to go. No problems at all. I've even seen some horrible cases where people put a hard collar on and then, get the person to jump up, walk around, and you're like, what are you doing? If that's the case, just get them to walk around without a collar. It was a ridiculous time period. Okay, so we need to maintain inline immobilization ourselves. We need to support the head and we need to keep it in line with the torso. So we need to avoid any movement of the spine, twisting, jolting, dropping of the head, anything like that. That's our responsibility to control that with our hands. Okay, and that's the best management. It was the best management when hard collars are in. The use of soft collars have come in, but the use of soft collars are only advisable, really, when the person is conscious and all you're doing is putting a little wrap around the person's neck to put them in a state of mind that says, don't move your head. You have a collar around your neck now, don't move your head. If you put that collar on an unconscious person, it actually gives you the false pretense that you're supporting the neck. And you're not. You need to use your hands, or you need to place them on a stretcher and build up things beside them. Now, all the recommendations said sandbags, but people in the military need to understand that we're not talking about large sandbags we use for defense or flooding. We're talking about basically cushions, like bean bags or something like that, that support the neck from rolling. You can use anything on either side of the head to support the neck from rolling, but that's the principle. Soft collars do nothing but give you a little memory peg for the patient not to move their head. As far as management go, they are completely useless. If the person is conscious, simply ask them not to move their head. The recommendations have come that if someone's in a vehicle and they can physically extricate themselves, then they do so. No help from us at all. They simply get out of the vehicle, they go to the stretcher, they lie down, and from there we maintain inline mobilization. The studies have shown that that is less likely to cause spinal cord injury than us maneuvering them, trying to drag them out. In the event they can't get out because of injuries or unconsciousness, then of course we have to help them out and maintain that inline immobilization. We need to restrict the movement of the patient until they can get to that tertiary facility. So evacuation is very important. If you're evacuating someone in the back of an ambulance, you need to have support on either side of the head, and it's really good practice for you to sit behind them, grab hold of their traps, and use your forearms to support the head as well. They need to be laid flat on a firm surface, okay, but a firm surface does not equate to a hardboard. Okay, stretchers are fine. Stretchers that you're bouncing around or stretchers that are in ill repair, not the best, but better than a hardboard, especially if someone has associated trauma that we'll talk about. Okay, so that's the general management as far as inline stabilization goes. That's the recommendations that are coming out. That's the improvements that have been made since hard collars have been taken out. So any of the new generation, hopefully you don't even know the legacy of horrible management of hard collars. Okay, but for those that have been playing the game for a long time, you need to get up to date with new recommendations, because the use of hard collars was causing much more harm than good for many, many reasons that I won't deep dive into today because of the length of the actual video that we're making. Once we're in a position and C-style mobilization is managed, we need to start thinking about all the other things that we need to do. So remembering we mentioned that these people are the ones that have already met the nexus criteria, or they fit into that high risk realm. So as with all our patients, we need to get involved and we need to monitor what's going on. And with those vital signs, it includes a BGL, spinal injuries linked to head injuries, linked to loss of mental state, which could be BGL. We've got to make sure that the sugars are in level, so not to sway our decisions. Okay, but on top of those vital signs, we need to start looking for signs of that neurogenic shock or shock in general. Now, remember that people in trauma can get associated shock from a whole bunch of other reasons as well. So just because you see shock doesn't automatically mean that it's neurogenic. And if it doesn't line up with the vital signs required, then it's probably not neurogenic and we need to go down a general trauma pathway. So we do the normal things, protect the airway depending on their mental state. Okay, we look at oxygen. We only provide oxygen if it's less than 94%, and you bring them up to a state that's more comfortable. Minimal oxygen is a general rule, and that same thing applies when you're dealing with spinal cord injuries. Obviously, if you have associated head injuries, you obviously do the management associated with the head injury itself. Perfusion is the biggest problem associated with proper spinal cord injuries, especially those that involve neurogenic shock. So we need to assess their perfusion status. We need to use crystalloids or blood if we have it, but we only use blood if it's not a spinal cord injury problem. If we're dealing with another problem that's causing the shock, then we can use blood because it's more likely blood loss from some other area. But if it's a pure spinal cord injury, then crystalloids is the fluid of choice. And we'll go into a few management principles from there, but we need to ascertain what's causing the drop in our perfusion status. Preventing hypothermia is very important. Spinal cord injury means loss of sensation and vasodilatory response of the region in neurogenic shock, which means that the patient is unable to regulate their temperature, especially in that area. So they lose a lot of heat. We need to consider medication. If the patient's in pain, and that pain is causing them to move around, which is wrecking your inline stabilization, then pain relief is a wonderful idea. If you're worried about associated head injuries, make a simple consult because you can also give pain relief to head injuries as well. Okay, so don't forget that pain is something that you can and should manage. Antiemetics are also a very important thing to worry about. There is nothing worse than having a patient in line, stabilized, and then they need to vomit. Okay, if you strap them to a board and they need to vomit, then that is the worst case scenario because aspiration is pretty much guaranteed. Okay, so they're your general principles, and from your overall vital signs that you get will determine whether or not we're dealing with a neurogenic shock or we're dealing with another spinal cord injury. And the way to tell the difference is with neurogenic shock, we're dealing with profound hemodynamic instability. Because what happens in neurogenic shock is everything below that spinal cord no longer has the function of the spinal nerves. And with that, it means they no longer have the sympathetic pathways to have any compensation. Okay, so that's what neurogenic shock is. It's an imbalance between parasympathetic and sympathetic. Because remember, most of your parasympathetic responses come from your cranial nerves. Your sympathetic responses come from your spinal nerves. Okay, so if you have that problem, there's an imbalance between the sympathetic and the parasympathetic stimulus. And this causes profound vasodilation below that spinal cord injury. So depending where it is, you have profound vasodilation below that spinal cord injury. And that obviously means a decrease in vascular tone, which means a decrease in resistance, which means a shit preload, which means a crap afterload, and then obviously all results in horrible perfusion to the tissues, which means the cells begin to die. Okay, now to make it much worse, if that's not bad enough, good neurogenic shock, depending where it is, you also have breathing compromise. So cervical regions 3, 4, and 5 are associated with the muscles to breathe. So your diaphragm itself and your intercostal muscles are controlled by 3, 4, and 5. So if you have a C5 injury, you pretty much will lose your intercostal muscle control. And 3 and 4 are branches that support the diaphragm itself. Okay, so if you were to lose that, The only thing you have to expand your lungs, muscle-wise, is apexual breathing coming from your accessory nerve in the parasympathetic nervous system. That's it. So you have a little bit of tugging from your accessory muscles that allows for breathing to occur. Stuff all. On top of that, you also can't have the general compensation of loss of perfusion, which obviously is increased heart rate. There's no sympathetic response, so your heart rate can't increase. So the signs of neurogenic shock are mostly associated with your hypertension and bradycardia, as opposed to the other shocks, which will have hypertension and tachycardia. Okay, so that could be a really good way to denote the difference. If you have good neurogenic shock, then you have profound hypothermia. Now, all these things coupled together means that you need to evacuate this person quick smart, because the management on the ground is impossible. And it really is, because you have a patient that needs breathing support, you have a patient that needs more fluids than you can actually give, and vasopressors and things like that are probably your only point of call, and you have a person that cannot even compensate for this lack of perfusion themselves. So the heart rate, doesn't matter how much fluid you put into them, the heart rate is still going to be low, which means the perfusion is still going to be poor. Your ventilation support is probably going to be subpar, which means the only chance for survival is to get to a tertiary facility that has an ICU, has a place that can manage these sorts of patients. So look out for these signs, do your best, and I say that absolutely sincerely because these patients are inherently difficult to deal with. Okay, do your best to get them to a facility where they can get the required care they need. Continuing on looking at that care, we need to acknowledge that we absolutely need to evacuate somebody to a facility that can support them. Okay, there's no questions asked. That's an absolute must. When we're evacuating someone, we need to think about principles of protecting the person. Now, a rigid board gets a lot of hate, but it's fine for short trips. And it's fine for patients that don't have a lack of perfusion. If you have a patient with a lack of perfusion and you put them on a hard board, then you increase the risk of pressure ulcers. Now you may think, oh, well, a little bit of pressure spot, not so bad. Pressure spots are the same as compartment syndrome, which is the similar physiology to crush syndrome. Okay, so these pathologies all link to one another, and a pressure ulcer in a patient can result in the same buildup of toxins that can cause the same problems that we have with compartment syndrome, because we're making a compartment syndrome of a micro area. That is what's happening when we do not look after pressure areas. And it does happen in fit young people in trauma that are placed on rigid areas. So long-term use of rigid boards, not appropriate. Using rigid boards to get people out of places, absolutely fantastic. But then use a scoop stretcher to pick them up off the rigid board, to put them on the stretcher to prevent the need for rolling. There is a way to do rolling, and there's all these recommendations, but in reality, every time you roll somebody, you increase the risk of spinal cord injury. So you only want to roll somebody once, if possible, in order to check their backs for wounds and that sort of things. And then once you roll them, you do not want to roll them again. If you're extricating someone and you can check their back, do it then. Okay, minimize movement. Remember, is a key principle. If you have to hold on to the patient long term, then you need to consider things that's going to prevent that patient from moving. So indwelling catheters, they won't need to go to the toilet as much. Nasogastric tubes are fantastic because it removes the probability of vomiting. Could load them up with antiemetics, but a nasogastric tube will absolutely remove the probability of vomiting. As far as a full sensory and motor exam goes, it's really a case by case. I'm not going to tell you not to do it. I'm not going to tell you to do it. But the general rule is, if you're going to do an exam, only really do an exam on a patient if it's going to alter your care plan. So if you're in a position that if you find out they actually have sensory deficit on one of the areas and you can map it to one of the spinal nerves, but you're already in spinal precautions and you're already treating them as a spinal cord injury, what does that information tell you? I can tell you that once they get to the facility, they're not going to believe your pre-hospital information that you obtained, and they're going to do it again anyway. Okay, so doing tests is obviously a great thing, but tests are really needed when it's going to inform a care plan. If it's not going to change a care plan, then really question why you're doing that test. And if that test is going to interfere with the patient or cause the patient to move more, and they're going to do it later, it is often better to wait until they're in the facility, that they get the results that they're going to listen to and they're going to act upon. Once patients like this get to the facility and they go through the management, they're usually in there for the long term. We have spinal wards, people to be looked after with spinal cord injury, that will go through extensive rehabilitation. It is what we do at the start that can decrease the probability of secondary injuries, and our management of the patients with potential spinal cord injuries can result in lessening effects of those secondary injuries, which means a shorter rehabilitation and a greater probability of returning back to normal life. So that brings us to the end of the spinal cord trauma lesson. Takeaway message for this is obviously what I just mentioned is the prevention of secondary injuries, but also prevention of the initial injury is also best. So if you're in a position to prevent someone from driving recklessly, prevent someone from taking risky behavior, then do so. There's a lot of young, full of life people that are sitting in spinal wards, all because of one event that maybe could have been avoided before it actually happened if somebody said something. So sometimes it's not just about the prevention of the secondary injuries, sometimes it can be about the prevention of the actual injury itself. But until next time, take care.